So just a little bit of a background on myself. Previous to coming to the Digital Health Agency, my background is in hospital, and I'm a training manager across IMR project rollouts. So a lot of my team I worked with were clinical nurses, grade 7 nurses were in my team. I am not a clinical nurse, I'll put that out there for you straight up, but I surround myself with great clinicians around me to make sure that we're hitting the right message. So if you today ask me something clinical, I may not be able to answer it, but I certainly can find out the answer for you and get it back to Jess in terms of how it relates to your practice and your workflow. But before we start, I would like to pay my respect and acknowledge the traditional owners and custodians of the land for which, past and present, of which we stand. And so in order to get the best value of our 1 hour session, please feel free to ask me questions as we go along. If you think this is something that you're already across, I'm more than happy to scoot through it. So if you just want to sort of flag to me, like if we get to accreditation and you think, oh, this is something that is a little bit overwhelming for me now, can I maybe talk to you in a bit more detail in the break? I'm happy to do that. If it's something that, you know, majority of you are comfortable with us skipping through because you're already across it, we can do that as well. So please, as we're going through the slides, please feel free to make it as interactive as you need it to be, and certainly share stories or share clinical scenarios where you can see that this might be relevant to your work practices in your clinical environment. So let's just quickly skip through, I think, the first couple of slides then. So basically, we're going to look at the benefits for you, and we're going to talk about data extraction. So how many of you do quite a lot of data maintenance at the moment in your practice, or drill down, or is this a new space for you to be understanding data? Okay, so we'll spend a little bit of time on that. So as you already know, you guys probably, how many of you have smart apps or Fitbits on you now? Yep. So we're already quite a digital Australian community. It's almost an expectation by some of our patients that our practices are digitally connected because they themselves are digitally connected. They want to know how many steps they're doing, what my heart rate is as I'm walking down the street. You know, they want their little alerts to be going off to say, hey, you've been sitting down too long. At work, they, you know, have added some technology where they can have standing desks so they can make sure, you know, they're still doing their count as they're going. So as a community, we're quite digitally connected already. And it's not just the Y-gens, or it's, you know, we also are seeing a trend in our older population now, over 60s, that also really want to be digitally connected. They're getting pretty digitally savvy themselves, especially those that are travelling around. They want to make sure that they've got access to their information, whether it's banking or whether or not they want to jump on, you know, TripAdvisor because they're about to go on this fabulous overseas holiday and they want to see, you know, the places to go. So they're very familiar with keeping track of things, whether it's through apps or whether it's through websites. So in terms of digital health, you guys are probably already across the different types of telehealth that were out there. We've got your telecare, we've got IMRs in hospitals. So most of you are familiar with an electronic medical records in hospitals, so it's very contained. It doesn't really travel outside unless it's then faxed or scanned. You know, it might take longer to get to you in your practice than the actual person coming back for their review after being in hospitals. And that's really where things like My Health Records fits in with this sharing information electronically. So at the Australian Digital Health Agency, My Health Records is probably just one of the things we're really looking at doing. We've also got quite a number of things that we're aiming for in terms of secure messaging. And we've talked about your different apps. So here's some basic stats about what people are expecting. So they expect value for money, to be frank. So coming into their GP visit and to see their practitioner, they want that time spent wisely. They don't want their GP to take up 5 minutes of their 15-minute consult, you know, trying to track down a fax, or where's that specialist report, or I don't seem to have that path report, where is that? So their expectation that you are giving them good quality service, and by having My Health Records, that's, you know, those sort of obstacles of where is the information fast, it makes it much more manageable for your GP to account for their time, which, you know, we know GPs love to be able to, you know, use their time wisely in terms of charging appropriately. So, you know, 4 times as many people want to access their own information than ever before. 45% say they have trouble accessing it. We were just having a chat about that, about how, you know, it's really easy to get into My Health Records, but that, oh my God, what's my MyGov username? And, you know, sometimes that can be a huge barrier for people to overcome. So they want that to be seamless for them as much as they can. And, you know, the idea to be able to, you know, track their health, but hey, just like I order my coffee down the road via a text message, wouldn't it be great if I could be connected electronically to fill my prescriptions? And, you know, my daughter sees a specialist, and it still floors me that as a specialist, if I have a new referral, that I have to fax it to him. I don't even own a fax. Very rarely would I use a fax these days, you know, asking, don't you just have an email address I can send it to, or is there an online portal I can upload this to, the scanned document? That's now part of our everyday lingo, that we expect that. So we can jump over this about, you know, the goal is really to empower you as a provider, as well as empower the consumer of controlling the record, and really we want to promote Australia as groundbreaking. So I'm just going to skip over these 2 slides because they're quite sort of, I think they're a little bit dry for you in terms of your clinical needs, but probably the one thing I'll really talk about is there's 7 key strategies, goals really, and the first is My Health Records. The second one is, you know, having the ability, secure messaging between providers to be able to send that information securely is really important. You know, sometimes we have in the hospital setting, you know, you might have a patient that comes to you for their regular IV treatment, but they've had something recently in a private hospital. You know, for those 2 specialists and organisations to try and talk can sometimes be really cumbersome, and having that ease of conversation without having to pick up the phone or tracking down a number is very important for people. This really then links into one of the third key areas, which is medication safety. And I'm going to show you a really important tool for you called the Medications Information View, which I think is your go-to place as a nurse. It's and any provider really, whether they're allied health providers that come into your practice, your GPs, is a really good go-to place in the record. Then the idea that we're educating our workforce digitally, such as conversations like today. We're really driving innovation. You saying to us, hey, this My Health Records, there's too many clicks if I want to get to the prescription. Can we try and get that clicking? You know, my GPs tell me they have to do 7 clicks to upload a document. Too many. They won't do it. And that optimisation is something we're always working towards, and there's a whole team at the agency looking after that operability for you. So I'm just going to skip over the next slide, which is really talking about My Health Records. Your notes are in there. But basically, it's the future of medicine, digital health. You can't get around it. Recently, with the medications rollout I did in Queensland, I was just saying the nurses in those hospitals had to do, just for the medications administration, 16 plus hours in the classroom on the computer of just medications administration. And then that on top of those 16 hours of it was, a little bit dry, to be frank, about, click here, fill in this field, it's mandatory. And then they had to then go into the work sim and do a further 8 hours in ward to get sign off to be able to use that system. So, that we're in that sort of place now where you need to be digitally savvy in your current practices, because to resist it is something that will just put you further and further behind, because this is a very fast moving train, digital health, for you right now. So here's some stats. Some of these stats don't look so great. For example, I'm just going to throw it out there. To say that there is only 50 referrals, that's because there's only one hospital doing it right now in the Northern Territory. So don't even think about getting e-referrals sitting in the system for you. They just won't be there. But then if we look at things like prescription documents, that's at 17,000 right now. By the end of next year, I have my little stats for that, we're looking at closer to 900,000 for those, just by the speed of which hospitals and community pharmacies are coming online with that. So you'll see a dramatic shift in these kind of number of clinical documents that are available to you as we get closer to the end of the year. So the more providers coming online, the more providers getting conformance software, which we'll touch on in a minute. But basically, these stats get updated every 2 weeks. If you're interested, you can have a look at that on the website. But they're our current ones there. So at the moment, we've got just over 6,000 GP practices across Australia that are connected to My Health Records.
Does that mean that with the prescriptions it's all done electronically, so there's no paper that you give to the patient that they then lose before giving it to the pharmacy? It's going direct to the pharmacy? Yeah,
so with the discharge summaries, in all hospitals that are connected electronically, they are automatically uploaded. The clinician does nothing. That just sort of seamlessly occurs. Yep. Some hospitals still will print that out for the patient to take with them, so if they want to check compliance and things like that, but that'll automatically shoot. In Queensland, sometimes the discharge summary might have some meds on there that maybe the junior house officers signed off or whatever, and then the pharmacists come around with the blue pen and gone, no, and written it. And if they haven't uploaded a second discharge summary to replace that. So what I always say is treat any of these clinical documents that are in your system like you would any other piece of information. You're still going to verify it with the patient. Is this what you're on? You're also going to verify it potentially with the provider that prescribed it if you think, whoa, that seems really not right. And it could just be a data error. Yeah. They might have typed in 100 instead of 10 milligrams for something.
But then will it be...
Their EMR should scream at them that they've done it. Yeah, you'll see it electronically, but like I said, in some hospitals, I know at the PA in Queensland, they will print that out for the patient to take with them. Other hospitals just might not waste the paper, to be honest. Yeah. It might just sit there. Because in hospitals, hospitals haven't caught up as fast, essentially, with My Health Records as we're really trying to get the primary health networks to catch up with. They are very focused on they're really madly getting to know their own internal EMRs that are coming on quite fast across states and whatnot. So they're, to start thinking outside their hospital setting is something new for them, and I'm heavily involved in the jurisdictions, so I look after private hospitals as well as public hospitals, Department of Corrections, and also Australian Defence, and Children in Care fall under us in jurisdictions. So a lot of those clinicians are being trained now in some states, and in other states like Queensland, it's sort of later in the year. So there will be, as you're talking to clinicians, or your patients might say to you, hey, when I said I had a My Health record at the hospital, they didn't know what I was talking about. So as well as your consumers getting the message, you'll need to be spruiking that to the providers throughout the year. You're sort of the baseline for us almost to sort of bring that news up to them as well, I guess.
There's also the PHNs are working really hard on it, but our hospitals
Yeah.
don't have compatible software at the moment.
Yeah.
So Victoria's going to be a bit behind.
Yeah, so Victoria's very different, like, so all the states differ remarkably different with not just internal connectivity. So Queensland has one IMR and that's it. So if you're connected, you're connected. New South Wales is very similar to Victoria. Yeah, so, yeah, but then they have HealthyNet that sits over the top to try and make their, so they're all at different stages. But for your patients, to know that if they've got a My Health record, you know, as they travel between states, or I'm not sure how much cross-border transfer patients have, like in Queensland, if you live in northern New South Wales, like Byron Bay, you can very easily attend a hospital in the Gold Coast without a problem. So that knowing that your record can travel across borders is really important for your patients, if they choose to.
I think we have that issue more Wodonga Albury, because Albury's got e-health records.
Yeah.
If you live in Wodonga, because Wodonga's Victoria, Albury's New South Wales. So
Yeah.
we have Mildura and Swankill, I think, have.
Yeah.
I find this all very interesting, given that we still can't even get a decent discharge summary on a fax.
We still.
Yeah.
So how is this going to jump to that?
Yeah.
They come across the fax and they've just got nothing. Sometimes they don't even have the patient's 3 identifiers on it.
Yeah. So I think so I think with the discharge summaries, they're very much trying to, they're very much working with the jurisdictions about not just, you know, must-haves on the discharge summary, which are our 4 key areas, you know. You want to know the allergies and alerts, the recent meds that have been given to them, what just occurred, and you want to make sure you've got the right patient identifiers and details in that. They're working very closely with them, along with making sure all our medications terminology is the same across, because you know that's another aspect to deal with. And another one that's really, I think, is really something that you would be utilising, and we encourage you to do. I know there's certainly a project going on with the agency at the moment, and Victoria, is the advanced care planning documents. That number's sitting really low at the moment, but New South Wales is about to turn that on in their hospitals. But that doing your advanced care planning, and I'll talk to you in a minute about the consumer portal and where they put that, and having those conversations, and why having those systems is really important on their My Health record, those clinical documents. Any other questions about?
Yeah, this might be a bit basic, but so I'm just wondering, like, say at the moment, if you want information from another GP about a patient, and you need the patient's consent, so a signature. If through the My Health record, how would that process work?
I'm about to show you that. So we'll jump into that, because we're just about, I'll jump through this, these few slides and take you to that, where we'll look at the consent to view and upload. So we've talked about really your benefits. You know, I don't need to go through this with you, only to really say, treat it as, I always talk about it as, treat it like it's just another book on your bookshelf. You know, it's just another repository, it's just another source of information, because at the end of the day, an IMR is provider controlled. Your clinical record systems in your GP office is provider controlled. My Health Records is consumer controlled. So if they don't want something up it, they have the right to refuse for that to be up. They can pull things down, they can hide things, and they can set secure locks on things, which I'll go through in a minute. So it's really important that you treat it like supplementary information you didn't have previously. So really, these are all no-brainers to you. You know, your doctors are going to spend more time. It complements your existing records. It's a really easy way to share confidential information, you know, rather than a fax, like we were talking, fax lying around with, you know, sensitive pathology reports sitting on, you know, the front desk in your GP office if it's fallen out of a folder, or it's sitting on the fax too long, or if your fax is not in a secure location, that sort of thing. So the clinical documents is what you've just asked your question on. The other stuff that's in there is the things like immunisation records, your Medicare stuff, your PBS information. Once somebody's My Health Records is created, that's when the record starts. That's when stuff comes in. It doesn't draw on past, other than your PBS information up to 2 years previous if they want that up. Okay, so it's basically a blank shell when you first create, and then we add to it. Individuals or their representative, their nominated representative, can put advanced care plans on, who their custodians or their nominated reps in there, their personal health summary, as well as emergency contact. The only thing that you can't open or see when you look in the patient's records is any personal notes they might have put in there. You can certainly use it as a conversation piece if they want to pull it up on their iPad and talk to you about something there. So I'll give you an example. You know, there might be nothing in a clinical document about someone you're managing through pregnancy. She's coming to see you for your regular checkups, and she happens to disclose that this is her second pregnancy. In her first pregnancy, she suffered a bit of postnatal depression. You can't see that anywhere. But you might suggest to her, I really think maybe pop that as a personal note to remind yourself that you and I are going to maybe talk about this over the next couple of visits, about some management strategies we can put in place to make sure that if you're feeling that you might, you know, be suffering postnatal depression, that we can certainly get some care plans together for you. You might even suggest to put that in her personal health summary, and you can certainly add to that. Or you might have that conversation that perhaps we could add this to a shared health summary, which is something I'm going to talk to you about. It's probably your number one clinical document you're going to be uploading.
So can I just ask, might be a silly question, I'm going to need it.
Yep.
We use best practice.
Yep.
And it's got up the top, like My Health Record.
Yep.
So if I was giving you my immunisations, that would automatically be uploaded, like I don't have to click anything.
Your immunisation record, that's being pulled from Medicare.
Yeah.
Yep.
So like when I send it to AIR,
Yep.
that's
It'll
automatically.
Yep.
I don't have to push that My Health Record or anything.
No. But if you have a patient that comes in and you say, oh, have you had your Hep C? And they go, oh, I don't know. And you go, let's go into My Health Record and just have a look. Oh, yep, there it is. Or, yep, no, it's not in there. When do you think you had it? Do you remember the GP? Like suddenly you now had to have a bigger conversation. So if it's not there, you know, it gives you it gives you a fast starting point. Then, oh, I don't know where my health book is, you know, all of that stuff.
So Medicare updates the My Health Record.
It's just it's an automatic connect.
Okay.
Yeah,
Right.
that happens in the background
Uh-huh.
for you, like the Gistard. So you can see here's a bit of a breakdown. You in your GP practice, your thing that you're uploading the most is a shared health summary. Your GP may do some event summaries. This is not really happening in your space at the moment. I think there's 17 specialists connected currently in Australia to My Health Records. Terrible statistic there for you. Take that off, don't even think about trying to find specialist letters in it yet. But certainly that's going to improve over time. The more specialists we get conformant software. This you're going to start seeing a lot more of. Definitely prescription dispensing records you're going to see. But you will be using that mainly. So you can check if one of these aren't what you use. You can certainly go to the link, it's in your slides, to see what other conformant software, but yours is definitely up there. And that's what you were saying? Yep, so you just click on My Health Records and then you jump in like that. There's a couple of things you really want to check. So you can see here you've got your patient's individual IHI, just like you would whenever you're talking to them in old school paper records. You want to, if you're jumping into My Health Records, just verify with them. Are these still accurate? Is this still right in terms of any of their demographic details? It's always important to do that in My Health Records as well. So that, so this is probably a good little, I call this a good landing page for you as clinicians. So this is the consolidated medications view. When you jump in here, all these blue lines, these hyperlinks, will actually take you to those documents. So there's two views you can look at. You can look at a document list, which is just a really big list, big catalogue of things, which you can then in the documents list, you can filter it. You can filter it by type as well as date. But if you want to reduce, I suggest this one's probably better for you. So let's say you want to, your patients come in and they've just recently been discharged from hospital and you want to double check their discharges there. So you can have that conversation with them about checking for medication compliance, for example. So you can click onto that discharge. You can see pretty quickly, this one was 12 months ago, so clearly this person doesn't go to hospital very often, but let's say this was last week. You can say, was it Dr. Brown's your specialist? Yep. Or maybe they don't know. And click on that, it'll say what hospital is, and then you can click on it and have a look at that discharge summary. So here's an example of some, I just want to quickly go through some of the type of clinical documents in there. So here you can see PATH and DI. PATH and DI is one of those tricky ones. Not all hospitals are uploading their PATH and DI reports yet. Queensland will be about July, but certainly some of the private PATH and DI, their stuff's currently going up. So there's quite limited reports at the moment. There's definitely no scans, so you won't see any rendered images in there. It's purely just the report. The other thing I want to just cover with you is the consumer or your patient won't see that result for 7 days. So in their portal on My Health Records, they can see that a particular document's been uploaded if they've had some pathology done that morning. It'll be greyed out with a lock on it, and that lock will sit there for 7 days. That just gives yourself, whoever their care provider, whether it's their GP or their nurse, clinical practice nurse, can maybe have that conversation first. The lock also has some exceptions to that, depending on which state or territory you're in. So different states and territories have something called what they might deem as sensitive results won't go up. So for example, HIV and things like that just won't go up. Their care plans can, but the pathology results won't. And the other exception to that is if the patient, the consumer themselves, says, I don't want that result up there, don't put it up. And there's 3 ways they can opt out for that. It might be on the hard copy PATH form, they might tick a box. It might be verbal consent, when they're at that particular pathology lab, or it might be in the electronic form they're filling out. So you don't have to suggest to them. It's, you know, you're not mandated to say, do you consent? It's standing consent. But certainly we all know as good clinicians that we will have those conversations with our patients to verify their comfort level about the sharing of their information between providers. Is there any questions about the PATH and DI?
They consider themselves to view their results within 7 days, so within a week they'll be able to find their own results.
Yep, they can just click on that. So they can go into their document list and see what results are there for them. I'll show you a screenshot of the consumer portal in a sec.
So is that before the doctors have time to talk to them?
The doctors have got 7 days.
Okay.
They've got 7 days to see them.
And release.
Yep, and have that conversation.
Yeah.
Yeah.
Sorry.
Yeah. So tell me why you find, is that...
I think coming from, I haven't been in general practice for long, but coming from an acute situation, I just think there's so much material that gets conveyed to a patient it's done in a sensitive manner and there's planning before they get that information. And because our generation likes to know, I just find it like, it's just a change, I guess. I couldn't imagine someone, because I think a lot of people might not get time to go to the GP in a week, and they think,
Yeah.
oh, I'll just check my results online. And then there's a risk that they'll be receiving some results that are quite sensitive, and they're on a computer at home or at work.
Yeah.
And then they start Googling, and then they will make an appointment with their
Yeah.
GP with that already known information, and they're coming with an expectation before they've spoken to a specialist.
Yeah.
I find it interesting.
Yeah, look, I definitely see your point. I put on my mum pants to clinicians when particularly doctors will say, well, I've got 100 bloody things in my message pool that tells me to look and review and blah, blah, blah. And I go, but when you take on your patient load, you take on the commitment to manage their plan, their care of, you know, their planned care. So if you've sent somebody to go and have a test, a week seems, I would say, is a reasonable amount of time for you to review that result. If you have made in your clinical decision making that it's important that they do this test, then it's your obligation to make sure you review that in a timely manner to get those results back, because your patient will be sweating on it. We all know they sweat on results. Yeah.
Yeah, it might force them to start doing weekly follow-up.
Absolutely. I sometimes say to, particularly to doctors, when they get nervous about transparency in medical record systems, they get nervous about it. And I say, it's very transparent. If you are doing what your ethical oath is telling you, if you are following your sort of standard policies and practices, whether it's your state legislation, your hospital policy and practice, this shouldn't worry you. These are like, it's like calendar reminders. Hey, this has popped up in my secure message. Don't forget to have that conversation with Mrs. Brown about her pathology report. This is just, you know, instead of your scratchy notes, this is just a really good filing system that you don't have to have a lot of paperwork with, as long as you're already doing, you know, great practice, I guess.
It'll push doctors to be better, I think.
Yeah.
7 days from the result actually coming to the doctor, or is it 7 days after doing the actual thing?
7 days from when it gets put up into My Health Records. And look, a lot of this is pretty instantaneous. You click a button, it's there. There's no lapse time. So once you upload something, it'll sit there. It's that fast.
I think if the doctors are concerned, like one of the good prompts is when you're taking, when the blood's getting collected or whatever, you just encourage them to make a follow-up appointment for, say, that result will be back within 2 days or 3 days.
Yeah.
If it takes a bit longer for that test, and that way they've already got that appointment made before that 7 days is up.
Yeah. definitely.
That way, if the doctors are concerned, they can just get them straight back in.
Yeah,
It's just prompting.
definitely. So this is what some of the, I just put this up to see some of, this is a best practice discharge summary for you. But definitely, you know, the general health providers, any of the clinical information, any of the test results, you know, any medication, both current and anything they may have ceased during hospital. I think that's important for you to look at, as well as any planned care notes. There's some free text fields in there as well. What's really important for the hospitals to be thinking about with their discharge summary is where in the IMR they might free text information to one another, and that's sort of hidden from view, I guess, from the consumer or the patient. This is very transparent. So whatever they put in will be here as well. So again, there's that ethical practice as well that they need to be ensuring they're following. And there's a lot of work around that compliance stuff for those doctors in this space.
Sorry, just to clarify a point. A doctor can access the information from elsewhere, can't they? Because if they said to them, I don't want this pathology result on my thing, the doctor can access it from elsewhere, they presumably.
Absolutely. The way you do pathology in DI, none of that has changed. Your current workflows, your current way of doing things has not changed. It's just one more place where it'll sit. Yeah. It's just, oh, by the way, we're adding this to a place where you can find it.
What I was saying before, within a week, a patient can convince themselves they're dying very quickly. And
Yeah.
then come into the doctor and go, oh my God.
Yeah.
The doctor will go, oh, well, that's not actually.
Yeah.
But
Yeah. And on the flip side, for both yourself and clinicians, having visibility of, you know, this pathology or diagnostic imaging being done in fairly good recency, you might decide, you know what, let's not redo that test, which is a great cost-saving measure as well, you know, and also, you know, the inconvenience of the patient, the extra radiation, all those sorts of things that people worry about. You know, suddenly we can see, you know, oh, well, actually, yeah, you did have that blood test and they did check these things as well. Patients like, you know, myself included, I'm not a clinician, I have a blood test. You might tell me it's because we're checking anemia, but you've, you know, taken a few more samples of other things just to be good clinicians. I don't take note, I just know you took a lot of blood out of my arm, you know. So ask me that, I'll go, oh yeah, I had blood 2 weeks ago, don't know what for, just to do my check, and, you know, straight away we can say it. So I think there's the benefit to the provider as well, both clinical transparency as well as cost saving is important. And here's an example of your prescription and your dispensing records. This will have PBS as well as non-PBS on it as well, which is important. And this is the one that you guys are going to be utilising the most in your GP. This is what you're going to be uploading, is your shared health summaries. A patient will, or in general practice, am I using the wrong terminology? Do you call them consumers or you call them patients as well? You call them patients, clients? Okay. So on a lot of the on our website and a lot of the paperwork, you'll see them referred to as consumers. I always refer to them as, in hospitals, my go-to terminology is patient. Okay. So there will only ever be one of these at a time on a patient. And really the 4 key things you're making sure you put on there is adverse drugs, meds, then meds history and immunisation. And you want to just check there. You obviously just want to make sure that you have all their sort of details correct, you know, their demographic details. When you're going to do this is usually like a GP health plan, when they're doing like an infant health check, that sort of thing's going to go up there, or there's been a significant change in their health. Maybe they've just recently had a stroke. You're going to update one of these. So they might sit there and, like, someone like myself that very rarely comes and visits you people, well, you know, mine might be 5 years old, okay? Is that very relevant to you? I would suggest not. So that would be a timely reminder to say to me, hey, you know what? Let's book in a time for you to do your GP health check, because I really want to make sure what we're putting in your shared health summary is up to date. So if anything should happen or you're travelling around, we've really got quite a recent version of your health landscape right now to your patient. So again, it's a good talking point. So who can do it? Basically, you have to have your registration with APRA to do one of these. So whether you're a GP, whether you're a nurse registered, whether you're an allied health practitioner registered, if you're an Aboriginal and Torres Strait Islander health practitioner, you can do one of these.
Allied health providers access it at the moment? I didn't think they could.
Depending on, they can, they just have to, let me just double check that for you. No, APRA. My apologies, APRA. They can do an event summary. Yep. So, which is another one. So if they've come for certain reason. They can, if they're registered with their HIH identifier, they can view.
Everybody in the room know about?
We're about to go through that, but they can view these. So this is, allied health people are going crazy over this right now, because this gives them a really nice picture of their patient that they're seeing. So yeah, they're quite keen on that. No free text field for things like if you want to. So in your medications, for example, you know, we've got their Ventolin and whatnot there. But let's any complementary, like St John's wort or cinnamon or something like that, you might not be able to put it there, but you can put it in the patient summary, because that's just as important that we know that, because we obviously know cinnamon can have effects in high doses on particular meds. So there's other places you might put information or suggest to your patient to put information. So any other questions about shared health summary? That's probably the one you're going to upload the most.
Is there any, there's no Medicare item or anything linked to completing that?
We'll go through some data coding in a sec. Okay. So this is what this is how the consumer sees what you see. Has anyone gone in and looked at their own consumer portal? Homework tonight. If you have a My Health record, go and have a look at it. You might want to add some stuff. Homework tonight, if you don't have a My Health record, you may walk away from today and think, I'm going to set myself up with one. Okay, so this is very user-friendly for them. This is very limited clicks. So you can see they just, it's basically got 4 key bits of information. They can click to hyperlinks and off they travel. And in there, then they can, you can see here, their little tracking about what they're doing. So here, access by an individual. They can set that up to send SMS alerts or email alerts to say, Joe Blogs at Stevens Road GP clinic has just looked at my latest discharge summary from, the PA hospital. And so if I think, I don't know who that GP is, I can certainly investigate, okay? If, say, they decide to put locks on it, there is security codes, obviously, that you as a provider will need to utilise to access that. So if you're not one of their authorised providers, you can't open some of these things. There is an exception to that, which I'll go through, which is your emergency override access. Very rarely will you ever use that in a GP clinic. That's more like, they've arrived at the ED, they have limited ID on them, they're unable to tell you who they are, what meds are they on. You can break glass function, jump into this to give you a quick picture of who you're dealing with, and that lasts for 7 days that the hospital and the providers within that facility can access, and certainly it'll send them alert to say break glass has been activated on your My Health record. So you're getting the understanding that it's very consumer driven, My Health records. So they have great visibility of how you interact with their record at any one time. And again, just a reminder, the one thing that you won't see is their patient notes. So when might you view their documents? Well, just like whenever you would go looking for information normally, you're going to be using your clinical discretion on that. How is it benefiting your care plan of this patient is when you're going to look at it. And so having that ability to go in and access is not an obligation. You're not obligated to use this as part of your registration. So it's at your discretion when you're going to be logging in. Some of the legislation that you're dictated by, you can click and log into that, but the one I'd probably really want to roll into is the Privacy Act, which basically says you need to take reasonable steps to keep your patient's information private. That hasn't changed to what you're, already. Now what it's saying is within the Privacy Act, it now includes the My Health Records Act as that other place where you need to make sure that you are keeping the information secure, you're not misusing it, and you're certainly not interfering it or making modifications to the patient record unauthorised. So in terms of consent to access, like what we've just said, the provider's permitted to access a patient record. You don't need to ask to access. Even if a patient has put locks on viewing, doesn't stop you from uploading to their record. That's really important to know. So you might not be an authorised provider to view, you can still upload clinical documents. Again, standing consent without having to gain that consent each time. So you're protected by law there as well. Any questions about that?
So each nurse and GP in practice has to individually register with Health Record to view. How do you get on and register?
I'll show you that.
Okay.
Yep. So we can skip through that then. Be assured there is fire wards. There's a whole cyber security department at the Australian Digital Health Agency that check and monitor patient records. There's to register, like we were saying, you need to be registered to use this, and there's certainly your authentication process that you go through to get through those firewalls. This is a little, if you want more information, spiel about security for your GP practice. It's actually a handy little booklet to have floating around in your office, particularly for your practice managers to have a little look at. So this is what we're talking about. You've got your healthcare event, and within the healthcare event, you've got the individual that you're caring, providing for. You've got yourself, so you need your HPII, and then your organisation's HPII. So within that, you will already have your number assigned to you. Okay, if you're not sure what that is, you can certainly go to the call centre, find out, and get that number. I put this slide in because it's things like the allied health people that may go, how do I do this? They can apply through here. They need to just follow this form. So you can just tell them where to find it. And then this is what the form looks like, and this is basically where they find it on our website. So they go down here, and then there's their registration process. you guys being APRA all should have that, okay? This website's great. I mean, you can jump in, you can log on for alerts, so new things coming online all the time, enhancements, that sort of stuff. They can spam you with that. There's certainly a place where you can go on, do some online training. So in your actual software you use in your practice, you can go on and you can have a play around. There's also a consumer portal, so you can go on and pretend you're a consumer, see their look and feel, so you know how to talk to them about their My Health records because you've played with it yourself. There's lots of little fact sheets, like I've brought one along here. So this is a quick fact sheet you can throw under your GP's eyes and say, hey, this is My Health records. I think these are some great benefits of why we need to do it. There's lots of consumer brochures and things coming out. Now I'll leave this one here with Jess because it's got Chris's name on there, and I know there's a few people that work with the Aboriginal and Torres Strait Islander health facilities, and Chris does a lot of that sort of education as well. So I'll leave that there for you. But this is a good go-to place for registration, information, training resources, that sort of stuff. And again, on here there's so this is what it looks like. They jump on, they apply now. There's a little bit of information that they can read about, what is My Health records before they do it to see if this is something they want to sign up with. Your GP should already have their HPIO, and it's a pretty straightforward process actually. It's not too cumbersome in terms of registration goes. It's pretty straightforward. Now there's some incentive payments and things like that there that you might look at. Really, most of this your practice manager does, okay? The only thing you're really going to worry about is data. What you put in here in your GP practice is what will spit out here on My Health records. So without being sort of stating the obvious, put rubbish in here, rubbish comes out. Quality data in, quality data out.
So what happens if the GP doesn't want data uploaded to their EPAS record?
Oh, they've got a little, yeah, there's a little click button they can say like does not consent to go up, that sort of stuff.
Yep.
Yeah, and that's here at this level, yep. In there now, yep. Yep. So I guess the key thing, I've given you a big list in here of there's lots of red and black notes. This is basically all the red is the RCGP standards, that says what you have to do in terms of data quality. And then there's some great benefits of why you need data quality. You've all gone to uni, you know about benefits, in terms of the richer my information, the richer the data, the better value I get out of the information. And really, the accreditation points and whatnot, the GP needs to look at in terms of making sure, to get their incentive payments, I guess, they're really looking at a 5% at this stage. A lot of them are doing a lot more than that. You really want to make sure for your accreditation points that your practice is getting, at least 75% of your patients some kind of detailed health record in there for you. Particularly allergies, aim for about 90% there. Past history list is a really good thing that you want to do. You really want to make sure that in the past history, you're really noting things like reason for contact, reason for visit, type of medication and things like that, and the reason for it in that. That's really good for when we're doing our data metrics, because let's say you've got some kind of program running. You can go in to your past history and you can pull that data. How many people here, like maybe there's this asthma management plan going on, you go, let me run some of my metrics on how many patients are in our system in My Health Records that actually we've got an asthma medication plan on them, and maybe we're going to run some education with them, or maybe it helps some of your quantitative data, and you can, you know, in terms of stock control, you know, as basic as that, stock control. Gosh, we have a number of our patients that come here for childhood immunisation. We particularly need to make sure we've always got that in stock. That's why we want to make sure our data is locked in there. There's a data checklist that you might look at, but really the 5 key things you really want to make sure all your records really have in terms of the data that you're putting into your local systems that can transfer over to My Health Records are things such as, you know, demographic, the meds, the history, patient's past history. Like I said to you, the moment the record gets created, that's where it starts. So if you can do some of that patient history information, add the richness to the data, as well as those allergies and immunisations to the record. So go in there. There's some steps there about how to add that in. Any questions particularly about data you want me to cover off? So you're really making sure you're coding in your system that transfers over to My Health Records for 3 key reasons in data is, you know, what's happening, what could happen, and also looking at things like what should we be doing better in our practice. You know, that's certainly going to have a benefit for your patient and your practice by making sure your data's in there. Is there anything?
Just a curiosity, is this an opt-in or opt-out system for, say, Dorevitch Clinical Labs and Melbourne Pathology?
Okay, so the opt-in, opt-out, there's sort of 2 parts there. Currently, for consumers, it's opt-in. By the end of 2018, it will be opt-out. So our patients need to elect when there'll be a 3-month window. It's yet to be announced, but at this stage it looks like it's sort of the middle of the year, where they will need to elect if they want to have opt out of the record. Otherwise it will be an automatic thing. Providers there's no obligation to opt in at this stage. People with conformance, it's certainly more people are coming on with conformance software, so there's no obligation to opt in or opt out. It's whether or not you have connectivity as a provider at this stage. Does that kind of answer it?
National program if not everyone's going to go on board.
Yeah, I think there's, you know, definitely the GPs are at the forefront of this. You know, there's a lot of GPs that are digitally connected in software, conformance software already, and we're certainly working with vendors to make sure their software is conformant. The hospitals and the jurisdictions are certainly on board with this. Where there's a little bit of hesitation, I would say, is more in your specialist field right now. Certainly the peak bodies are working very closely with them to get those specialists that are still using voice dictaphones and handwritten paper notes in file systems. They're going to take a little bit longer, absolutely. And this is, you know, this is not static. You know, this is an evolving thing. So at first you might go in there and there might not be a lot in the record at all. You know, this time in 2 years' time, you know, we're hoping it'll be substantially different, particularly when by the end of the year it's opt-out. You know, currently in trial sites where there's been one in Nepean's Blue Mountains and one in Queensland, the opt-out rate is less than 10%, you know, of population.
And that's the consumers.
And that's the consumers. So, you know, with the consumer push for this, you know, it definitely then, you know, speeds up the providers to catch up. definitely. So here's some of the training places. This is, you can see when you go there, you click on, you just need to there's test patients for you to play around in. There's quite a number of those software applications that you were talking about to have a little play and see what you can do in there. And there's lots of these sort of how-to instruction guides up on the web for you. Hence why I sort of haven't overwhelmed you with information now. So there's how-to guides on how to enter your data. There's how-to guides on, how to do a health summary. I know you've got a lot coming into your brains over the next 2 days in terms of lots of clinical stuff, but certainly this is a valuable space for you to go back to and reflect on in your work and just have a bit of a play. There's also some online training modules that you might like to do. I would give myself some time for that. They take about an hour to get through. Yeah. So yeah, you definitely will get your CPD points in that. If you're more tactical, which I know a lot of nurses are, I really suggest a good place to go is the software, the play environment for you. So yeah, here's your key messages. It's really important that you are advocates of sustained use, I guess, is what the message for me to you is today. That yes, it's a bit tricky with some people not coming on you. Yes, it's a bit tricky with allied health professionals. A lot of them don't have consortment software, but definitely moving in that space. Yes, some of the hospitals are a little bit slow with it and a little bit insular, but certainly this is a moving space and you guys need to really advocate that. And there's basically, if you want more info, go there. If you need some troubleshooting, if you're having trouble with access or any of that sort of stuff, go to the helpline. Press number 2 for provider, because it'll give you a million options.
So we sort of promote this then to people, saying, are you registered, would you like to be? Is that what we're doing?
Yeah, so definitely there'll be consumer comms going out in terms of, there's not a big media campaign, definitely. So it'll be through, a lot of digital stuff. But you might have people querying you, oh, what's this about opt-out? You'll hear that term. What's this about I have to opt out of something? So you really, I would suggest, if you think this is worthwhile, which I definitely think it is, you should be saying, yes, you can opt out, however, let me tell you about the benefits. This is why it's good to have it, when you travel, if you want to be linked, to have good visit. Yeah, definitely. Yeah. Your advanced care planning. Those early conversations you might have depending on where they are in terms of needing those advanced care plans.
Is there going to be like advertisement of the fact that at the end of 18 everyone's automatically going to be signed up? I'm just thinking like there's those disadvantaged people that, low socioeconomic, or rural remote areas that don't have access to, technology to opt out or might not even be aware that this is happening. Like if there's not that kind of...
There's a couple of different campaigns, but there's sort of the general, very sort of subtle consumer campaign going out. It's more provider focused this time in terms of hard to service and hard to reach groups. So like, your detainees, your juvenile youth and detainee centres and that sort of stuff, people with English as a second language. There's a whole different body of work in that space. So all this information in 17 different languages in low literacy, sort of, I guess, what I call consumer collateral. So it might be some videos that are 30-second videos that are available in waiting rooms and things like that are targeted at provider and consumer. So there's a number of ways we're doing it. Some of it is basically one-on-one. We sit and do the form together because you're not allowed to hold a pen in this particular facility. So those people are even being identified. Yeah. So today I'm really just talking to you guys about general people, general population.